know Dr. Mahapatra, all of us know. He is the man behind the show, Dr. Manori and all doing wonderful job of getting us all together on this common platform. Dr. Mahapatra is consultant and director of nuclear medicine at Seven Hills and with a very major, inputs in nuclear cardiology in the country. And we welcome Dr. Mahapatra for his talk on PET in the diastolic dysfunction.
My topic, I think many of the important things my colleague Dr. Prabhu has already covered. So there may be a little bit of repetition, please don't mind. I will be speaking on role of PET in diastolic heart failure. I will confine only to diastolic heart failure with preserved ejection fraction, not with coronary artery disease with reduced ejection fraction. So, as today morning I had already spoken, the heart failure is a major public health problem affecting more than 5.8 million people in US and 23 millions worldwide. It is a leading cause of hospitalization in older patients above 65 years and also in women. It is very common in older patients and women. Heart failure is a clinical syndrome, not a disease, and can occur in patients with reduced and preserved ejection fraction. So the chance is 50-50. 50% of the patients with HFpEF, heart failure with preserved ejection fraction, and HFrEF, heart failure with reduced ejection fraction. So the division is 50-50. So what are the criteria to diagnose HFpEF? Ejection fraction, when you will have by echo, it is more than 50%. And as Dr. Bijan has already spoken, elevated increased BNP or pro-BNP levels. Then in echo, Professor Dr. Parasar has spoken relevant structural information like left atrial enlargement and left diastolic, LV diastolic dysfunction parameters. So what is the pathophysiology? Diastolic is a process by which the heart returns to its relaxed state and time for coronary flow, resulting in cardiac perfusion. So as you know, the relaxation process of the left ventricle is identified in 4 phases. One is isovolumetric relaxation. Then second one is early rapid filling after mitral valve opens up. Then a period of low flow during mid-diastole. Then the late filling of the ventricles from atrial contraction. So how PET imaging helps in diastolic heart failure? There are about 4 ways majorly. Non-invasive assessment of sympathetic innervation with PET and SPECT. SPECT has already been covered by my colleague Dr. Prabhu with iodine 131 or iodine 123 MIBG. And the PET radioisotope is C11 hydroxyephedrine, C11 tagged with HED in short form. Then comes the very important information which I am going to speak in detail. Non-invasive assessment for myocardial flow reserve or coronary flow reserve accurately quantifies myocardial flow reserve at peak stress to at rest when there is a normal ejection fraction and there is a reduced myocardial flow reserve. Then detection of infiltrative cardiac disease, amyloidosis, sarcoidosis with heart failure with preserved ejection fraction. Then finally, the stress-met myocardial perfusion scan to rule out underlying CRD like hypertension, diabetes, and other causes where the ejection fraction will be reduced. But we can diagnose, we can rule out the ejection fraction is not reduced, then we can label them as HFpEF. So what is the non-invasive assessment of sympathetic innervation in patients with HFpEF? First in the series is the assessment of sympathetic innervation. As Dr. Prabhu has already spoken, SPECT and PET imaging using radiolabel analogs of norepinephrine, iodine 123 MIBG, and mine was PET tracer C11 hydroxyephedrine shows their uptake representing presynaptic nerve function in the heart in LV diastolic dysfunction. More specifically, iodine 123 MIBG heart to mediastinal ratio, which I'll show you, and iodine 123 MIBG washout rate. These are the 2 parameters which have proved to be the most useful indices in this study. Similarly, suppose with this study, decreased global C11 HED retention index indicates worse cardiovascular prognosis. That means you can do a prognostic study, so worse cardiovascular prognosis and all-cause mortality in patients with HFpEF. With higher spatio-temporal resolution using PET tracer. But still, iodine 123 MIBG is the best. Additional prognostic information over transthoracic echocardiography or available biomarkers. Echocardiography cannot tell you the prognosis. So prognostic information can be done, can be told if we do a iodine 123 MIBG or C11 HED PET tracers. So how do you analyze that? Little bit of the most common indices to the heart mediastinum ratio, we calculate HM ratio, heart mediastinum ratio, and the washout rate. Then region of interest with the same pixel is put on the heart and the mediastinum to obtain the mean count rate. Then the heart mediastinum ratio is calculated. Then the washout rate is calculated. So the formula is washout rate percentage is equal to early image, heart counts and minus mediastinum count minus delayed image, heart counts minus mediastinum count divided by early image into 100%. That gives the washout rate. So here you can see the MIBG. So you can take here the mediastinum and the heart, and the ratio can be calculated. Ratio more than 2.24 is very good signal, is having a good prognosis. And here also same thing, we can calculate the heart mediastinal ratio and the washout rate. So coming to this particular graph, the cardiac death, what is the relation between cardiac death in HFpEF versus HM ratio? So if you see the 2-year cardiac mortality, you can find the less the HM ratio, the mortality goes high. See, so 2 years cardiac mortality less than HM ratio 1.20. But here 1.20, 1.5, 1.59 ratio of heart mediastinum ratio, the 2 years mortality decreases. But more than 1.60 equal, the cardiac mortality is quite very good, excellent. So then comes the non-invasive assessment of coronary flow reserve or the myocardial flow in HFpEF patient. Absolute quantitation of myocardial blood flow, which I was talking to you, coronary flow reserve is an established method of quantifying the blood flow in individual coronary artery. Recent studies have suggested a role for coronary microvascular dysfunction, which happens in HFpEF. So cardiac PET is a non-invasive quantitative imaging modality capable of accurately quantifying myocardial flow reserve, the ratio of myocardial blood flow at peak stress to myocardial blood flow at rest. So in patients without significant epicardial disease, there is no luminal narrowing, MFR can be considered a marker of microvascular function and a surrogate for coronary vascular health. MFR CFR has been shown to have prognostic value in patients with HFpEF. MFR may be reduced in HFpEF patient compared with controls without HFpEF, representing microvascular dysfunction. HFpEF is associated with lower global and regional MFR than non-heart failure controls. The mean global MFR is 2.16 plus minus 0.69 in HFpEF patient, which is significantly lower as compared to the hypertensive control or normotensive control with about 2.54 plus 0.80 and 2.89 plus 0.70. So what are the PET tracers available? Oxygen 15 on-site cyclotron, very short half-life. Nitrogen 13 ammonia, on-site cyclotron can do. Rubidium 82 chloride generator produce, and the F18 fluoride, which will be introduced very shortly to the market. So here you can see the ammonia picture and the rubidium picture images and oxygen 15 picture. I think you all will agree with me. Nitrogen 13 ammonia and rubidium 82 is a good tracer with a good distribution. Next is how we acquire the little bit list mode imaging. We do a radionuclide injection at after doing a CT scout image and CT attenuation. We inject nitrogen 13 ammonia 4 minutes, then get a rest image. First do the rest scan, then you do the pharmacological stress scan. Here we inject a nitrogen 13 ammonia after giving a pharmacological stress with adenosine diphenol. Then we do the gated stress. This is called the stress, pharmacological stress, as compared to the resting scan. So here you can see this is called the RV, and this is the LV, the least mode acquisitions. Then you can see the curve showing oxygen 15 water is the highest tracer uptake, but still ammonia and rubidium is not bad. So coronary flow reserve is calculated by coronary flow at hyperemia divided by the coronary flow at rest. Average global coronary flow reserve in young volunteers is 3.6 to 4.2. CFR in patient with risk factor is reduced to 2.8. CFR in patient with stable CED 2.0. So here is a patient of 45-year diabetic patient, stress and rest ammonia cardiac PET study. You see the normal perfusion scan, but here if you see the arteries are quite normal, 2.4C, 2.73, LAD circumflex and right coronary, and TOT is a time activity curve. It's normal. So here you can see the graph study where you can see the HEPA patient, the global MFR is 2.21 and or even 1.88 and LAD or 1.9, LCX 1.89 as compared to the normotensive control 2.89 and 2.9. So this definitely shows there is a reduced CFR in HEPA patient. So the detection of infiltrative cardiac disease, amyloidosis, sarcoidosis with HEPA, already sarcoidosis is responsible for 30 to 85% of death. The value of FDG AVID PET studies for identity cardiac sarcoidosis. Langa et al. They performed a retrospective study of 30 patients with systemic sarcoidosis referred for FDG PET. They found with sensitivity and specificity of 85 to 80%. Focal or diffuse FDG uptake is suggestive of active cardiac sarcoidosis, which you can, this is a young man with a arrhythmia presented with us in our department, and we did a suppression test and we did a resting perfusion scan showing normal, then followed by the high fat and low carbohydrate diet for a week. Then we inject the I think I'll show the heparin and other thing which increase the free fatty acid level. That is the MRI picture of the same patient. So in here you can see the hyper enhancement, and here also you can see the MRI picture. Then we did a resting perfusion scan of the same patient. Ejection fraction is normal, 56%. Let's see how it looks in sarcoidosis. See here, clear-cut focal increase uptake in the anterior area, in the anterior and the inferior area, showing active sarcoidosis. So PET imaging cardiac amyloidosis, which Dr. Prabhu has done. Only thing I want to tell little bit of ATTR variety transthyretin versus AL acquired monoclonal light chain variety. PET tracer, we started with sodium fluoride F18, then C11 targeted tracer uptake in ATTR, but PET tracer with F18 fluor beta P is coming, diagnosing and distinguishing AL, that is light chain amyloidosis versus ATTR. So it diagnosed AL variety. But again, as Dr. Prabhu has already spoken, TC90M PIP or MDP or hydroxy MDP, this is a bone scan agent. It's a very easily available procedure. You inject that and see the uptake in the heart. Here, this is a normal scan. Here you can see the uptake is here in the myocardia. Then the Perugini score, as Dr. Prabhu has already told, grade 1, grade 2, grade 3, Perugini score more than or equal to is 100% specificity and 93%. Bukhari et al. They showed technician PIP imaging with a hard to control long ratio more than 1.5 detected ATTR-CR with 97% sensitivity and 100% specificity using bone scan agent technetium MDP or technetium HEDP. Here you can see the grade 1 grading, the grade 1, grade 2, grade 3, grade 3 you can see that, grade 1 is 0. And here the suspected cardiac amyloid flow chart, if the bone scintigraphy is negative, cardiac amyloidosis is unlikely. If negative scan indeterminate, you do a SPECT scan and find out the uptake in cardiac. If it is a positive, this is a ATTR variety of cardiac amyloidosis. But if it is negative, then you can go for a lab test at the monoclonal protein present test referred to hematology department. Then stress PET myocardial perfusion imaging in early diastolic dysfunction with preserved ejection fraction. Then we can use various PET tests, but mainly right now stress nitrogen 13 ammonia, stress rubidium 82. Then these are the two agents. Fluorescence has not yet come. So this is why you can see rubidium 82 PET tracers which you can do as stress and rest. imaging photograph, I don't know how to tell you, stress and rest image. Then here you can see the ejection fraction is 50%, increased to 63%, and it is normal. But here this is typical of a HEPAP with reduced ejection fraction with a coronary artery disease, 60 fall at 49. So here in one study, you can see the imaging as well as the flow reserve, coronary flow reserve. You can see CFR in all three arteries, it is abnormal. So nitrogen 13 ammonia, you can do also the ammonia study, but it requires a on-site cyclotrons. But if you see the sensitivity and specificity, PET scores our SPECT around 5% in sensitivity and specificity around 2-3%. So the flow chart, stress, rest, myocardial perfusion, normal perfusion, if it is there, you do go for a myocardial blood flow quantitation, and then you can see the myocardial pressure is more than 2.5, 2 to 2 point, MFR is less than 2, normal, borderline abnormal. So preventive medical intervention is required here. But if it is abnormal perfusion, do a coronary angiography, and then it is called HEPREP, reduced ejection fraction. So MVP quantitation also will help in case of balance ischemia and other things. But HEPREP, these things are required, that myocardial flow reserve. So this is a multimodal imaging where you can see the SPECT and the PET, they are good in amyloidosis, sarcoidosis, and microvascular dysfunction as compared to constrictive pericarditis and other things where other modalities scores over us. So concluding, nuclear cardiology procedures are no doubt the state-of-the-art procedures in the present day clinical practice in diagnosis, prognosis, and guidance of therapy in HEPAP. Coronary microvascular dysfunction in small vessel artery disease becomes unhealthy when there is a damage to the inner lining and building of plaque in the larger coronary arteries, producing reduced MFR can be evaluated correctly using PET tracers, either with nitrogen 13 ammonia or rubidium 82. Then you can find out the myocardial flow reserve. Myocardial sympathetic denervation or associated with advanced diastolic dysfunction in HEPAP using either quantitative iodine 123 MIBG, planar or SPECT or C11 hydroxyephedrine PET to clarify the prognostic value in selecting patients for immediate intracardiac device, for synchronization or medical therapy, which we are going to discuss during the latter part of the session, especially for low global retention index. Further, infiltrative diseases such as cardiac sarcoidosis or cardiac amyloidosis can be diagnosed using PET imaging, affecting FDG or affecting fluor-beta-P in AL variety of amyloidosis, and technetium antivenom, EHDV or HMDV, bone-seeking agent in ATTR variety of amyloidosis, the gold standard for diagnosing, especially for ATTR variety. Important comorbidities of HEPAP includes arterial hypertension, which Dr. Pancholi has told, diabetes, obesity, pulmonary disease, CRF, liver disease. Stress, PET, myocardial perfusion is of great help to rule out CAD in HEPAP. Thank you very much for your attention. I would like to invite all the attendees, speakers, chairpersons to actively participate, come and attend our physical conference, most probably, yes, in Tajlands in 28th to 30th October next year in Mumbai, Bandra West. Thank you very much.
Thank you, Dr. Mahapatra, for that lucid talk on the various mechanisms, various isotopes used for determining various roles of various agents in diastolic dysfunction, be it coronary or infiltrative disease like amyloid, sarcoidosis, and MFR and CFR.